Hello everyone, my name is Emer, my pronouns are she and her, and I am the Patient Support Manager here at Melanoma Canada. I will be facilitating tonight's webinar, and I'm very lucky to be joined by two very special guests. First up, we will hear from Dr. Roxana Mititelu, leading dermatologist and Mohs surgeon at the Carton Clinic in Toronto, known to her patients as Dr. M. We will also be hearing from a patient's perspective when we are joined by Bruce Ballingall later this evening to share his personal story. Just a little bit of background about who we are before we kick off tonight's webinar and who we are and what we do. So we advocate and support Canadians living with melanoma and skin cancer. We provide helpful resources, education, psychosocial support services, and we truly envision a world with zero melanoma and skin cancer related deaths. We are on a mission. We want to support melanoma and skin cancer patients, caregivers, and medical professionals with current and coordinated information and services. We want to educate people in Canada on melanoma and skin cancer, on prevention, early detection, and treatment options available. We want to be that united voice of the melanoma and skin cancer community. We want to advocate for early detection, timely diagnosis, and effective treatment options. So without further ado, please allow me to introduce our first expert speaker of this evening. We're going to be joined by Dr. M, who is a dual board certified dermatologist and Mohs surgeon in Canada and the US. She graduated in the top 10% of her class at McGill University, where she also completed her dermatology residency and was awarded the Residence Teaching Award. She completed an American College of Mohs Surgeons accredited fellowship at the University of Toronto and now practices at the Carton Skin Clinic in Toronto, specialising in Mohs micrographic surgery for non-melanoma skin cancer and facial reconstruction. I do want to give a small trigger warning before Dr. M starts her presentation, as she will be sharing some graphic images. Please do reach out to us for support after the webinar if you find these cause you any distress. So I'm going to stop sharing my screen and hand over to Dr. M.
All right. Thank you so much for that kind introduction. Before I begin, I just wanted to give you guys a little bit of background of the work I do. I work as Emer mentioned at the Carlton Skin Clinic, which is located in Toronto, and I work with the best group of people. So we're a group of Mohs micrographic surgeon, a plastic surgeon, and a lot of staff that support our work, lab staff, nursing staff, and we really specialize in non-melanoma skin cancer, particularly on the head and neck, and we do also wide local excisions on the body. And I'll go over what this means later on. And we try to provide our patients collaborative care and actually do have patients from across Canada. So we're happy to help if you ever need it. So let's get started. The outline of my talk tonight will be definition, so just getting us all on the same page. We're going to talk about how common are these skin cancers? Are the rates increasing or decreasing? Where do they occur on the body? Who are they affecting? And what do they look like? And what are the treatment options? So, what are non-melanoma skin cancers or NMSC? It's actually just an umbrella term for every other skin cancer other than melanoma, and this happens to be made up of primarily basal cell carcinoma or BCC and squamous cell carcinoma, SCC. There are some other rare tumors like atypical fibroxanthoma, which is referred to as AFX, or microcystic adnexal carcinoma, which is referred to as MAC, but these are really rare, so we're going to really focus on the first two. How common are BCCs and SCCs? They're the most common cancer in Canada and definitely the most common skin cancer. The good news is that the majority are very easily treatable in an office setting. So we actually don't have a Canada registry that tracks how many we actually have, but we do have some data to guide us with these numbers. In 2014, the Canadian government looked at non-melanoma skin cancer and they found to have 76,000 just in that year alone. And of these cases, 78% about were basal cell carcinoma. So basal cell is more common than squamous cell carcinoma, which only made up 22% of cases. That translated to a lifetime risk that they calculated for basal cell carcinoma to be 1 in 8. So this is Canadian data. Out of 8 Canadians, 1 Canadian during their lifetime may develop a basal cell. And for squamous cell carcinoma, it's 1 in 20 Canadians. And what's happening to these non-melanoma skin cancer? Are they increasing or decreasing? So we have some data. The most recent study comes out of Ontario. It's published by Dr. Chan at Women's College in 2021. And he showed that initially the incidence, so the frequency they were occurring was decreasing until about 2003. And since then, there's been a steady increase. And they calculated the increase to be about 30%. So they're still very common, very relevant discussion to have. Who gets non-melanoma skin cancer? So it affects men slightly more than women, of a ratio of 1.5 to 2 to every 1 woman. It's increasing in incidence with age. So the older we live, the higher chance we are to develop them. And this same Ontario study showed that the highest incident were males over the age of 50. So now let's talk about mortality and morbidity, meaning why do we care about these? So for basal cell carcinoma, they rarely metastasize, meaning they rarely ever spread to lymph nodes or organs. So it has a very low mortality, which is very good for patients. However, they can have high morbidity. They can really impact on function or quality of life. So just some warnings, some clinical images will be coming. I'll try to give you guys warnings before I show any images. So this is a small basal cell carcinoma, and this doesn't spread. However, it's occurring in a very important anatomical location. It's the lower eyelid and covering somebody's lacrimal duct. So having something grow in that area can really impact not only function, but also cosmetic outcomes too for the patient. This is another basal cell carcinoma that occurs on the nose of a patient. And you can see there's some hemorrhagic crust, which just means some dried blood. So it's growing and bleeding in a very important area. What about squamous cell carcinoma? They have a local reoccurrence rate about 3%, so the chance of it coming back to where it was treated. Their chance of it spreading to lymph nodes is about 4%. And the chance of somebody actually dying from this disease is 1.5%. So it's very low. However, there are certain high-risk subsets where metastatic squamous cell carcinoma can really have a high mortality. So this is just to emphasize that it's really important that we try to catch and treat these squamous cells and basal cells as early as we can. So just some warning of a clinical image coming. So this is a patient that had a very large squamous cell carcinoma, which is not pictured here, but I did include a picture of a lymph node. So that's this firm lump over their clavicle bone. And that's was the squamous cell carcinoma spreading to that lymph node. Where does it occur? It most often occurs on the head and neck area, but they can occur anywhere on the body. And now let's talk about why do we get them. So we'll start off with basal cells. There's 3 main categories. The first is genetic, and that is your pigmentary phenotype, which refers to having fair skin, always burning in the sun, freckling, having red hair. There are certain syndromes, such as basal cell Nevis syndrome, or what was previously called Gorlin, that predisposes patients to basal cell, and they often are diagnosed before the age of 20. Environmental exposure is very important to discuss because that's something that we can have some sort of control over. So, UV exposure, which we'll go over into more detail, predisposes to basal cell carcinoma. Ionizing radiation that is can be found in imaging like CT scans. Um, so, what is often the clinical scenarios that a patient may have had many CT scans throughout their life, and this radiation could predispose to basal cell. The good news is that the technology has really advanced, and the ionizing radiation released by modern day imaging devices has very low ionizing radiation, so it's less important risk factor. Chemical exposure is usually through occupational, so through somebody's work. Arsenic, coal tar, soot, nitrogen mustard, polychlorinated biphenyls, and 4x4 bipyridyls. Those are all usually found in certain occupations, like working with pesticides would be a common exposure. And the last category is immunosuppression, particularly patients that have had an organ transplant. They are more predisposed to basal cell carcinomas. What about for squamous cell carcinomas? So you'll see here the risks are very similar. So the same genetic risk factors. The syndromes are slightly different, but these ones are very rare. So albinism and xeroderma pigmentosa. Environmental exposures are very similar. The unique ones to squamous cell carcinoma is the human papillomavirus, or HPV. Certain strains can predispose to squamous cell carcinoma. Cigarette smoking is a risk factor, immunosuppression, as we previously discussed. And there are some very rare clinical scenarios where, for example, a patient with a chronic, not healing wound, I've often seen leg wounds, they can develop squamous cell carcinoma in those wounds. Long-standing rashes like discoid lupus erythematosus, lichen planus, or lichen sclerosis, particularly if not treated, can the patients can develop squamous cell in those rashes and porokeratosis. Often these are really rare diagnoses. More common we see is like UV exposure and of course genetic factors. So let's take a moment to talk about UV exposure. I think it's really important to talk about because that's something we can't control. We can't control our genetics for now, but our sun exposure we can try to control. So basal cell carcinoma are known to be formed due to intermittent intense UV exposure. And I think this is really relevant for Canada because we have many months of the year where we don't have a lot of UV. But then in the summers, the UV exposure is very intense, or we often travel down south and go to sunny destinations. Sunburns, as well as a risk factor for basal cells, particularly before the age of 20, so in the younger years. For squamous cell carcinoma, the risk factors tend to be cumulative intense UV exposure. So there was a study from California where they have constant sun throughout the year, and they actually have almost as many squamous cells as basal cells. And sunburns as well will predispose to squamous cell carcinoma. And of course, I can't not mention tanning beds. Tanning beds, there's no safe use of them. They've been shown to increase the risk of squamous cell carcinoma by 2.5-fold and basal cell carcinoma by 1.5-fold, and of course, melanoma, we know. So, how are these skin cancers diagnosed? So, it's often a clinical exam, meaning you see your practitioner and they'll often do a skin exam. This is a cartoon that I made of somebody getting a skin exam, but ideally, your practitioner will look at your body and examine the lesions, and they have very suggestive features of how they look. Often you may see your practitioner use a dermatoscope. So that's this tool pictured here below. It magnifies by tenfold, and there's certain features on dermoscopy that are very suggestive for skin cancer. So how do they look like? We'll first start off with basal cell carcinoma. We'll go over the different subtypes. This is the nodular subtype. Often patients will tell me, I have this pimple that's growing, bleeding, and it's just not going away. And in this case, it's a basal cell. This is another example of the nodular subtype. And in our textbooks, it's often described as having a pearly appearance, which describes how the light reflects from it. You can see in this picture, the light is really gleaming off the lesion. The next subtype is the pigmented. These ones can be brown or black in color, and they really stand out. And I find patients will seek care very fast for these because they're worried about melanomas, but it's actually a basal cell. This is the superficial subtype of basal cell. And the clinical story patients tell me is like, I had eczema or psoriasis, and I thought it was just that. And I tried to use my creams, but it never really went away. And then they finally sought an opinion and they were found to have superficial basal cell. The last subtype is the sclerosing or morphiiform basal cell. And I find this one to be the trickiest to diagnose because it really looks just like a scar. And I really trust my patient's history on this because they'll tell me, I never had a trauma in this area. Nothing's ever happened. And they just suddenly develop that scar. So it really makes me think twice about these lesions. And they're clinically a little bit trickier to treat too because it's hard for us to tell where do they start and where do they end. Now, what about squamous cells? There's not as many clinical subtypes. Um, these are two classic squamous cell carcinomas. The key for them is they often grow faster than basal cells. Like patients will say, last month I had nothing, but now I have this lump growing really fast. And they tend to be more keratotic. And that just means it's more scaly. This is a subtype of a squamous cell. It's called a keratoacanthoma, a fancy word, but they look very distinctive because they look what it described to be as a volcano-like appearance with almost like a crater in the middle. They actually have a better prognosis, and there's been reports of them even clearing by themselves without treatment. So next step for the diagnosis, your practitioner has done the exam, maybe they've used a dermatoscope. How do they confirm what it is? What can be done next is a biopsy. There's many ways to do a biopsies. I'm just showing you a picture of one way. This is called a punch biopsy. So there would be local freezing to the area, and then a small sample is taken and sent to an external laboratory. The results, depending on the province you're in, can take from 2 weeks to 4 or 6 weeks. Now let's talk about the different treatments. So you have biopsy result and it shows that it was a non-melanoma skin cancer. The treatment's really divided if it's low risk or high risk. So low risk lesions are ones that are small on the trunk and there's certain histological subtypes. So what is read on the pathology report features of that can determine if it's low risk. So for low risk subtypes, one of the treatments that can be done is called curettage and electrodesiccation. So that's also done at a local office, local freezing to the area. A curette is used, so this is this tool here, and electrodesiccation, which kind of burns the blood vessels. Next treatment option is cryotherapy. That's using liquid nitrogen, which is very cold, and it essentially causes very much like a ice burn. Creams are also an option. These are topical chemotherapy creams, and they work by finding these skin cancer cells and really destroy them. So while you're using the creams, they can cause quite a significant reaction to the area, lots of redness, burning, and peeling. And there's two usually that are mainly used. They're 5-fluorouracil, and that's used in conjunction with calcipotriol sometimes, and imiquimod. And they have a lot of different brand names. The last treatment option that you can consider is photodynamic therapy. There's not a lot of coverage across Canada for this, but it's a very interesting treatment because a cream is applied to the skin cancer. And then when a patient is exposed to a certain light, it could be a laser or a blue light or even a red light, the cream gets activated and will only destroy those cancer cells in that area. So how do you decide which treatment is the best? Well, there's many factors and it's obviously a discussion with your practitioner, but there's patient factors, your preference for duration of treatment, the side effects. There's tumor factors, the size, the subtype, and the cost of the treatment and what is covered by the province. The cure rates is something that I'm always asked about. So if these treatments are used in the correct tumor, so in these low risk ones, the cure rates are really high. So EDNC has a cure rate of 92, cryotherapy of 93. Some of the creams can have cure rates of up to 90%, and photodynamic therapy, 93%. But just take those numbers with a grain of salt because these studies were done in the perfect scenario in these really low risk ones. So what about for high risk tumors? So those are the ones on the head and neck, certain pathological subtypes, and larger lesion. Radiation is a treatment option, and that's usually done in a hospital setting. You see a radiation oncologist, and usually have multiple sessions to treat it. Wide local excision is usually done in a local outpatient office. It's where the practitioner will take 4 to 6 millimeter margins of extra skin around the tumor and surgically excise it. And then the next option is Mohs micrographic surgery. Um, there's more variable access to it in Canada for it, but it is mostly available in most major centers. Um, and I just wanted to show you guys this video of it because it's more of a visual representation of what we do.
Mohs surgery significantly reduces damage to the surrounding tissue while effectively removing all traces of cancer. First, your fellowship-trained Mohs surgeon marks the tumor with a pen. While there is no need for the patient to undergo general anesthesia, patient comfort is a priority. So before the Mohs surgery procedure begins, the affected area is numbed with a local anesthetic. Then the surgeon excises a saucer-shaped piece of tissue with 1 to 2 millimeter margins around and below the marked border. Patch marks are made on the skin to maintain specimen orientation. A bandage is placed over the patient's surgical site, and he or she will wait comfortably while the excised tissue is taken to an on-site lab where it's prepared for microscopic evaluation. Many Mohs procedures can be completed in several hours, but some cases will take longer. Your fellowship-trained Mohs surgeon, who has training in skin pathology, carefully examines the tissue under a microscope to see if the cancer has been completely removed. If residual tumor is found, it's marked precisely on the map. A second Mohs layer is excised only in the positive area. This process is repeated until all the margins are free of tumor. Your fellowship-trained Mohs surgeon will explain the most effective means of surgical site closure and postoperative care at the time of your procedure. Small, simple wounds in appropriate areas are allowed to heal naturally by a process known as second intention. Most wounds are closed with a linear repair, a side-to-side stitching of the surgical site. To close a circular wound, extra tissue on either side of the circle is trimmed so that the suture line lies flat. Larger or more complicated wounds may require skin grafts or a flap, which closes the surgical site by moving adjacent looser skin to fill in the wound. There will be some scarring once the area is healed, although scars from Mohs surgery are often smaller and less visible than those from other excision procedures. As a member of the American College of Mohs Surgery, your Mohs surgeon has undergone residency training in dermatology prior to a rigorous 1 to 2 year fellowship in Mohs micrographic surgery and dermatologic oncology, during which he or she performs more than 500 cases. These cases not only include the pathologic interpretation of both common and unusual tumors, but also performing routine and complex reconstruction. Our primary goal in performing Mohs surgery is to cure your skin cancer and to preserve normal tissue. Compared to other skin cancer treatments, Mohs surgery has a very high success rate, up to 99%. You can trust the hands of a fellowship-trained Mohs surgeon to give you the optimal result.
So that was a very good video from the College of Mohs Surgery. They're probably a little bit biased, but they're right. Mohs does offer the highest cure rate. Despite the Mohs micrographic surgery cure rate being 95 to 99%, the other treatment options are also really high cure rates of 91% of radiation, wide local excision of 90%. So there's really high cure rates for all the treatment options. So I'd like to just give you another warning. There's going to be some graphic images. So this is a Mohs defect, so it's surgically removed and it's stitched up a linear, this is called a linear closure, and you could see the cosmetic outcome is really good. This is one of my colleagues' patients that had a large squamous cell on the temple. She did a combination closure of a flap, which means moving skin over, and a graft. And you could see here at 3 months, they have very good outcomes. So what about for patients that have unresectable or metastatic disease? So when the tumors have spread, we have treatment options for that as well. So for basal cell, there's two medications, vismodegib or sonitigib. They're oral pills that can be given for metastatic or unresectable basal cell. And there's off-label use of immunotherapy. And then for squamous cell carcinoma, there is now an immunotherapy medication approved by Health Canada, which activates a patient's own immune system to try to treat these squamous cell carcinomas. And this is the pictures from their clinical trials showing that they have very good results. So this patient had a lot of metastatic disease, and after treatment, they have most of their tumors are all gone. So it's really exciting and hopeful time to treat these patients because I think we really do have a wide variety of different treatment options. So in summary, we discussed that non-melanoma skin cancer are mostly basal cell carcinomas and squamous cell carcinomas. Basal cells and squamous cells are the most common skin cancers and cancers in Canada, and we discussed they are increasing in incidence. Risk factors are genetic, environment, and immunosuppression. And sun safety is an important modifiable risk factor. So trying to practice sun exposure safely. There are various treatment options for both low risk and high risk disease, all with excellent outcomes. So I'm really glad that you all shared your evening with me, and I'd like to thank Melanoma Canada for having me tonight.
So thank you so much, Dr. M, for that very informative and educational presentation. Before I introduce our final speaker this evening, I just want to touch on a couple of things that we at Melanoma Canada are doing to try to achieve our mission of zero melanoma and skin cancer related deaths. Firstly, I would like to draw our attention to our Mobile, which is our portable skin screening unit that is helping ensure Canadians have access to skin cancer screening. Our Mobile has been on the road for 3 years, and this year we expanded our tour to cover 4 provinces, including Ontario, British Columbia, Alberta, and Quebec. We've visited over 106 communities since starting this May, and we have our final tour stops this coming week in Quebec. We have offered free skin checks, no appointment required, and we have completed over 785 skin checks so far this tour. and identified 947 suspicious moles or lesions. 541 have been suspicious basal cell, 179 have been suspicious squamous cell, and 188 have been suspicious melanomas. The Mobile's impact has been significant since it started on the road 3 years ago. The mission was very clear: help educate Canadians about sun safety, promote early detection, and timely diagnosis. We do have a few remaining tour stops, as I've mentioned, in Quebec this coming week. And for more information, you can check out our website at momobile.ca, and I'll share it in the chat after. We do also offer free monthly skin check reminders. You can scan the QR code on the screen or sign up on our website. We will share the link again in the chat. We will alert you every month in line with the full moon to complete your own skin check at home. We also include a video on how to conduct that skin check at home and some helpful tips on skin health. So it now gives me great pleasure to introduce our final speaker this evening. Joining us from the west coast of Canada, Bruce is a retired police officer of 40 years, or should I say a peace officer, as he likes to refer to himself as. Bruce is one of 6 brothers who have all battled various forms of skin cancer. Bruce has received a basal cell, a squamous cell, and a melanoma diagnosis at different stages throughout his life. He's going to share a short overview of his personal story with us all this evening.
Good afternoon from the west coast of Canada. My name is Bruce Ballingall. My own journey with skin cancer started way back in 1986 when I had the what they called 5FU on my face. But first, a little bit of background. Me and my 5 brothers, we were mostly raised in sunny Winnipeg, Manitoba. Our mom, bless her soul, she would put us outside at 8 o'clock in the morning, the noisy 6 boys that covered in baby oil, and we'd be out there all day. And now each one of my brothers and myself are dealing with some sort of skin cancer, and 3 of us are battling melanoma now. But yeah, and that's what the way it was back then. And then in my teen years, I spent my first few summers on the beaches of sunny Manitoba, and then my dad moved us out to the west coast, so I got into the real beach life on the west coast. And I tried for all my teen years to get the perfect, what I call lifeguard tan. Well, it didn't work out so well because our background is Irish. I was fair-skinned redhead, and I spent my time on the beach going pink, red, peel, and never thought anything of it. It just happened. And then in 1986, I had a really good dermatologist, and they ended up sending me for Mohs surgery on my lip, which took eight hours of this surgery, but it got rid of the cancer. But then through the years, I've had many zaps. I always thought the dermatologist got paid by the zap because I have so many zaps. But now I'm very blessed to have a really awesome dermatologist here in Nanaimo on Vancouver Island, who sees me every 3 months. But a couple of years ago, I had a little bit of a dot on my head, and so we took a photo of it and sent it to my dermatologist the day back in North Vancouver, and he brought me in right away and did a surgery on my head. I've had 5 surgeries on my head now, but during the first surgery, second surgery, they took 12 lymph nodes out of my neck, and sadly, they found what they called P16 squamous cell carcinoma, where my tonsils used to live. So I went through 32 treatments of radiation for that, and it worked. But this was 4 years ago, and I'm still experiencing some side effects from the melanoma because it was in my throat. I have some throat issues now with the scarring that the radiation caused. So it's still. I'm cured of it more or less, but I'm still having the side effects. And then I had a PET scan, which are magical treatments, and they found what turned out to be metastatic melanoma in my lung. And I truly thought I was gone. I thought my life was over because sadly a friend of mine lost his wife 3 years earlier just metastatic melanoma. But my good doctors told me that there was a treatment now. Sorry, I'm getting a little excited here. The immunotherapy, which they called the magic bullet, and it obviously is a magic bullet because here I am. So yeah, so it's gone, but I'm still battling different types of basal cell, and then matter of fact, there's something coming back on my lip. But what complicates biopsies for me is I had a heart issue back in '05, and I've been on blood thinners ever since. So every biopsy is an adventure because you bleed. But so now I'm going to have one on this lip to try and see what's going on because I think it is that, no, I can't say the name of it, but the good doctor, she mentioned it, and hers, it's on my lip, and hopefully we can get rid of it because, I want to keep living. But, the main thing that my message I can say is that it's up to us, each individual, to save their own lives. We have to be sun smart. I mean, I spent all those years on the beach here in Canada. I'd go to Maui, and just never thinking of it. But now, and I would ski. Everybody thinks it's the beach. Well, no, skiing, the sun when you're skiing, especially if you don't have any head protection on, it is very dangerous too. So we really, really have to sun smart ourselves, but spread the word about sun smart. You can't take chances because, believe it or not, the sun is trying to kill you, and the sun will kill you if you don't defend yourself from the sun. So there's so many things out there now: hats, umbrellas, sunblock, so many things that we can use and help educate other people so that we don't have to let the sun kill us. We can beat the sun if we're sun smart. So I ask everyone on this tonight, please be sun smart, but be an ambassador for Melanoma Canada and spread the word. Spread the word that we have to be sun smart or we're going to lose our friends or our family. So please be sun smart and look after ourselves and help other people look after themselves. And we can all live happily ever after. I thank you for your time. And please spread the word to be sun smart because the sun will kill you. Thank you so much for your time. I appreciate it. Now back to Emir.
Thank you so much, Bruce, for sharing your story and for those high level messages for everyone. You've shown incredible resilience and determination, I suppose, over the last number of years. And from all of us at Melanoma Canada, I want to thank you for your continued support to us through various fundraising efforts and events like these. Bruce's story may have brought up some emotions for people on the webinar this evening, and I just want to finish off the presentation by highlighting some of our support services. We do offer email and phone support. We're available Monday to Friday, 9 to 5 Eastern Time. We will share the contact details at the end of the webinar for anyone looking to avail of our services. We do also offer cancer coaching, which is a one-to-one support service offered to melanoma and skin cancer patients and caregivers. The support is offered over the phone or online. These services allow clients the opportunity to talk through their experience in a safe, confidential space with a cancer coach. And these sessions are completely free to all clients. We also run a melanoma and skin cancer support group twice a month, the first and the third Wednesday of every month at 6:30 Eastern Time, allowing patients to connect. We do have a peer-to-peer support program. This program is where we try to match patients with other patients of a similar diagnosis, similar treatment plan, similar age, or similar province. The program allows patients to connect with each other via email or phone and gives new patients the reassurance that there's someone who has already been through a similar journey to them and they're ready to walk along beside them. We do have a very active online community and we have private Facebook groups for basal cell and squamous cell patients and caregivers. We often share our patient stories on our website and social media channels. And if anyone would like to reach us on Facebook or Instagram, for example, you can find us at Melanoma Canada. Finally, we have a lot of publications that have been written with the help of specialists in oncology and dermatology, and are useful for melanoma and skin cancer patients, caregivers, and healthcare professionals. We've just launched our 7th edition of the Melanoma What You Need to Know Guide, which is available in 7 languages. We have English, French, Arabic, Chinese, Portuguese, Punjabi, and Spanish. We also have patient guides helping you understand basal cell carcinoma and squamous cell carcinoma, along with other rare types of skin cancer and treatments. All booklets can be downloaded and ordered from our website. Again, we have a QR code which we will share and circulate after this webinar. However, with the Canada Post strike, we do encourage patients and users to download the publications from our website to ensure you receive it in a timely manner. And finally, just some future events that are coming up. I know I've mentioned our Mobile, the final tour stops are in Quebec and they're coming up this coming week. You can check those out on our website. And we also, if there's any pickleball fans on the call tonight, we do have a pickleball tournament. Our Smash Out tournament is happening in Montreal next Saturday. To that, you can also donate, volunteer, or host an event for us at Melanoma Canada, and all information you can find on our website. Finally, I just want to share our contact information. Again, you can take a snap of the screen and we will circulate it and put it in the chat.
Could I say one more thing before?
Of course.
I kind of spit. But the most important thing for all of us cancer survivors, because that's what we are if we're still here, we're survivors. 2 things I've done through my 5+ years battle. I've always looked after my caregiver, because the caregivers really work hard to help us. And without caregivers, we wouldn't have as many winners as we have. And then the medical team. I mean, my medical team has been amazing. And the one thing I've done for everybody I've come in contact with, every technician, clinician, doctor, I make them laugh, because they see a lot of sad things in their days. And I know the doctor will agree with me, but we can make them laugh. And that's the only tip we can give them, because we don't pay them, is to make them laugh and give them some joy. That's all I have to say. Thank you.
Thank you, Bruce. Dr. M, we have quite a few questions coming in for you. If you want to join us back on screen. So we've had a few through. First one up is, does vitamin E ointment help with surgical scars?
Yeah, this is a very good question. Something I'm asked every day. And sadly, I wish it worked, but right now the current evidence says that it's not any better than placebo. So just using a moisturizing cream. So things that there are evidence for is scar massage, so massaging your scar, silicone gel or silicone sheets have some evidence as well. And then, of course, there's cosmetic things that can be done, but I would recommend seeing your practitioner to discuss further treatment options. Sometimes lasers can be considered, microneedling. So there's a lot of options out there, but sadly, the vitamin E doesn't have strong evidence right now.
That's great. Thank you. Next one, again, is for you. Is it important to have suspicious squamous cell lesions removed quickly? And is there any reason why they're so itchy?
Yeah, very good question. So we do try to treat squamous cell carcinomas quickly because they do have a slightly higher risk of spreading. But as I mentioned in my talk, it's still a low risk of spreading, less than 5%. Is what I quote patients. For this reason, though, we do triage our patients at least for 2 weeks. So we book everybody with squamous cell carcinoma with a diagnosis for 2 weeks. So we aim to be as fast as we can be. And then itchiness, the itchiness hasn't ever been actually like scientifically shown in studies, but I would say a lot of my patients tell me this. My personal theory about it is that's likely maybe irritating some nerves in the area. So yeah, anecdotally, I've heard this a lot, and there hasn't been any studies to really help guide us what to do if there's itchiness. Yeah.
That's great. Thank you. Another one around basal cell. What should patients be watching out for basal cell returning in the same area or a new area? Is there any helpful tips for them?
Yeah. So what I tell patients is like, especially after treatment, the first 3 months you're really healing and actually scars continue to improve over 2 years, but things should be slowly improving. So if you notice any new bumps, anything bleeding or growing in that area, it's better just to get an opinion about it and get it checked.
Great. Thank you. Um, Moving more to, I suppose, the patient. Dr. M, how would you or how do you address patient anxiety about scarring or cosmetic outcomes after Mohs surgery?
Yeah, so that is a very valid concern, and I sympathize with patients. It's not easy to go through surgery on your face. Um, the what I explain to patients is like first and foremost, ideally we should remove the skin cancer because letting something grow and get bigger on your face will actually have poor cosmetic results. And then especially with the Mohs micrographic surgery, we can try to take us small margins as possible. So I'm aiming for 1 millimeter margins and then really trying to do the best reconstruction possible for each individual patient. And everybody's face is a little bit different. So we really try to put that into consideration. And it often heals really well. The face is very well vascularized, meaning a lot of blood vessels. So it does heal better than the rest of the body, actually.
That's great. Bruce, I would actually ask you maybe the same question. Would you have any advice for patients around anxiety, around scarring, and you've gone through numerous surgeries yourself? Would you have any advice for patients coming behind you?
Yeah, I just say, it happened, but it's kept you alive. And so you may not be as good looking or as beautiful as you once were. So you make up stories about the scars. You got some really good, entertaining stories about how you got the scar. It doesn't have to be the truth as long as it's entertaining and helps relieve the pressure and you make somebody laugh.
That's great. Thank you. Humor is always helps along the journey. Um, Dr. M, we've had quite a few questions. I'm just kind of around this sort of topic. I'm just going to kind of bundle them together. But lots of people have been asking around red light therapy and your opinions on that, and if patients who have had past skin cancers, should they use red light therapy, or is there any recommendations not to, especially around basal cell and squamous cell?
Yeah, so I'm actually not exactly clear on is the question regarding these new devices that I see all over social media, like this red light mask. Um, if it's that red light mask, the science behind that has been, it's actually not new science. It's been around for at least like 30 years that I saw the first study. And it has some benefit in healing and rejuvenation, but it's a very small benefit. So I don't think, like, I don't see much harm in using them, but I don't see them as particularly effective at preventing basal cell carcinoma or squamous cell carcinoma.
That's great. And I'm just going to ask you one more, and I know you're still replying to some in the chat, but last one that's come in from to me is once you've had your squamous cell removed, how often should you see your dermatologist ongoing?
Yeah, so I think this is a really important topic, and as you mentioned, part of Melanoma Canada's mission. Our sadly in Canada, our system is quite strained, but in an ideal world, I tell my patients every 6 months, because we do have evidence to show in the after the diagnosis of a non-melanoma skin cancer, in the first 2 years, you have a 50% increase of developing another spot. So that in my mind, I see those first 2 years critical to really follow patients closely. So I think 6 months would be great. I don't think it has to be with a dermatologist. Some family doctors, nurse practitioners are very capable as well. So, but having somebody look at your skin is helpful, especially for areas you can't see yourself, like your back, your ears, your scalp, all these areas.
Amazing. Thank you so much, Dr. M, for answering those questions. I want to take this opportunity to thank both of our guests tonight, Dr. M and Bruce. Thank you so much for your time. Without your expertise, your knowledge, and your willingness to share your personal story, we wouldn't be able to promote and provide webinars like this.
May I say one more thing to interrupt? But one more
Absolutely.
to everybody. I hope they're still online.
Yeah.
Make a noise. Talk to your MLA. Talk to your MP. Sign the petition, because we need more dermatologists and more dermatologist nurses to help us survive. Please get involved. Don't be a spectator.
Absolutely, and the petition has been linked in the chat, folks. So thank you both, Bruce and Dr. M. I also want to thank our sponsors who make these webinars possible. We have Merck, Pfizer, and Regeneron. Without the sponsorship and partnership with these organizations, we wouldn't be able to provide tonight's webinar. Thank you all for joining us, and I hope you've found it useful. And I can't wait to see you all back in a future session and a future webinar in the new year. Thank you, everyone. Good night.